Hi everyone. We'll just give it maybe 2 more minutes, and then I think we'll get it started. Yeah. All right. I think let's get started. It's 3 minutes past. So I'm sure whoever else wants to join us, I'm just going to trickle in. So yeah. I hope you guys can hear me okay. If not, please give me a shout. And also, you can see the slides coming up. So we're just on the starting page now. So this is our final weekend session. So some of you might have attended the previous weekend sessions that we've had before. So all we're doing is we're going to have 3 different sessions in one broad topic together. Broadly speaking, we're going to do some questions, we're going to do some answers, and we're going to discuss and teach on the topics that are going to be involved in the questions. Today we're going to finalize. So we've done surgical, we've done GP, so now we're going to do A&E. So we're going to focus on the medical stuff, and we're also going to do a bit of psychiatry as well, because you see a lot of psychiatry in A&E. So yeah, let's get started. So I'll be doing the first set. So we have chest pain and breathlessness. We've got a bit of collapse, major trauma, sepsis, and psychiatric emergencies as well. So, question 1. So we've got a 24-year-old man. He's got shortness of breath, wheeze, and chest tightness. He does have the history of asthma, and he's used his reliever inhaler quite frequently over the past few days. You've got his examination results here. How would you manage this patient that just presented to you in A&E? I've got a C, which is good. Well, actually, very intense. Don't know if anyone else has any other options apart from C. Okay, we've got 1D coming in as well. Oh, we've got an A moving in as well. Okay, very, very even split. Okay, fine. So yeah, D. The correct answer is D. In fact, so I'll explain a little bit about why that is. I think from the question stem, hopefully the split would have been between A and D. They're quite similar in terms of the answers, but it's the fine print when it comes to managing someone with asthma to see what's happening. So yeah. Let's talk a little about asthma. So I presume that everyone knows what asthma is. So you get this kind of, it's a chronic lung condition where you get bronchospasm. When it comes to acute asthma, so things that you'll see in A&E or maybe sometimes GP as well, actually, you want to assess them. So you want to take a history. And in the history, it's really important that you ask about the previous exacerbations. So you want to know how many they've had recently, and how severe they were. It's important to know if they've ever been in ITU, if they've been intubated for it, if they're taking their medications, and then you can also, when you do your clerking, you should also take into consideration other risk factors that could increase their risk of complications from it. So if they have a learning disability, if they're isolated, etc. You want to examine them, get their observations. If you can, not always possible, you want to get a peak flow and make sure that you know what their usual peak flow is. Obviously, if they're hypoxic, you want to get an ABG. And then if they have any viral symptoms, anything like that, you might want to do some swabs as well to find an effective cause. We've talked a bit about the severities in the previous sections as well. So you get moderate, severe, life-threatening, and near-fatal asthma. So life-threatening, near-fatal are the ones where you get hypoxia. So in life-threatening, you would have a low oxygen drive with some other signs as well. In near-fatal, you get a raised carbon dioxide, because it shows that your body is getting exhausted and you're not able to breathe it out. In moderate and severe, you should have a decreased CO2 in your gas. And then to differentiate between moderate and severe, it's just you need to know, unfortunately, some of these things. So any of the severe ones will put them into the category of the severe. Okay, so in this case, we obviously don't know the peak flow, so we can't really comment on that. But if you have a look at his sort of respirate and heart rate, you can see that his respirate rate is 22 and his heart rate is 98, and he's also able to speak. So it doesn't quite qualify for severe, so we're going to be in moderate. So when it comes to moderate, just here, bigger in case you wanted it bigger. So yeah, if you wanted moderate, what you do is you generally give oxygen if they need it. They shouldn't really need it. And you give a salbutamol. So salbutamol you give by a spacer initially, and you can give prednisolone. If there's no improvement of the spacer, you can do nebulizer as well, and that still goes on the moderate. But that's just your step up thing that you need to know. If you're severe, you go straight for the nebulized salbutamol and the ipratropium and the steroids as well. So that would be the option A. That's something you chose. If it's life-threatening, you do all of the above. I see, yeah. I mean, oxygen, it kind of depends on the saturations. So I think in this case, the saturations are actually fine, if I remember correctly. So it's 95. So if it's 95, there's not really any point in giving oxygen, to be honest. And yeah, it's not going to hurt him, to be honest. But yeah, intubation, definitely not. So on the life-threatening, you can also do magnesium sulfate and aminophyllin. usually, especially in my hospital, if you start giving immunophilin, you need to discuss with ITU because they might need intense monitoring. Also, if they become drowsy, if there's any concerns about their airway, you can talk with ITU very early on. That's very important. What else? I think that's pretty much it. Yeah, you need to act quite fast. Asthma. I've seen asthma in the resus this week. It can be quite intense. So just knowing and recognizing your sick patient. When they're really unwell, they might sit in a tripod position, try and help them breathe, things like that. So then get your seniors as soon as you can. And I think that's the main takeaway. Yeah. Oh, with steroids, pred, if they can swallow, if they can take oral hydrocortisone, just yeah. If they for some reason are unable to take it orally, you can do hydrocortisone as well. All right. I think that's it. I think there's something else I wanted to say, but I got out of my head now, so we're just going to move on. Okay, so we've got question 2. We've got a 72-year-old woman, and she's now got severe COPD. She's got worsening shortness of breath, and she's got this productive cough as well. She's quite drowsy when she arrives, and she's using her accessory muscles to breathe. Her stats are 88% on room air. She gets some oxygen via Venturi masks. She gets salbutamol, ipratropium. She gets oral pred, and she remains still breathless. You repeat her ABG, and this is the gas that you see below. What is the most appropriate next step in her management? So this is again one of those questions, unfortunately, where you need to know certain cutoffs. Yeah. Now we've got someone who's very keen on intubation. Several people who are very keen on intubation. There's a trend with the asthma. We've got some ongoing anaesthetist here. Right. So the correct answer is actually C. And I'll explain to you in a second why the answer is C. But it's very good that you guys have recognized that this patient is unwell. She's not improving with the medical treatment. So we need to think about how to get more oxygen, or how to improve her better, basically. Okay, so COPD, again, you know the condition, I'm not going to go over it. When you assess someone with COPD in A&E, you want to take a history if you can. So you want to figure out what is the COPD usually like, what is the baseline like, and what are some features that they have. So they'll probably be short of breath. They will have a cough most likely, but it's a question of if it's a dry cough or it's a productive cough, and what does the phlegm look like. If they had a fever, wheeze, or any respiratory symptoms, sore throat, etc., that's very important to know because those could be exacerbating it. So with COPD specifically, you want to know if it's an infective or non-infective exacerbation. And then if it's infective, what is the causes, bacterial, viral, etc. Observations, like usual, you want to examine them, specifically the chest. Probably do an ABG, and what you'll very likely see, which you have also seen on the previous one, is that you're going to have a type 2 respiratory failure. So your both CO2 and your oxygen are going to be deranged. You're going to have an acidosis, and you're going to potentially have raised bicarb. That's a chronically raised bicarb in order to compensate if they're a retainer as well. Okay, so that's important to know because if they're a retainer, you're going to have a lower oxygen scale of around 88 to 92. However, some people with severe COPD do actually have a lower scale than that. So always check as well if there's anything in the notes previously. Do an X-ray just because you need to make sure that there's if there's an infection anywhere. Typical X-ray usually looks like this. So this X-ray, just the main thing that you can see there, it just shows hyperventilation, hyperinflation of the lungs. So they've got these massive lungs in order to compensate. If they're coughing, definitely get a culture from that. If they have viral symptoms, definitely get viral swabs as well. Because COVID can drive it, influenza can drive it as well. Okay, so now that we've assessed, we think there's a COVID exacerbation, we're going to do again a pretty step up approach. So salbutamol, you can give it nebulized. You usually give it via air as opposed to the asthma because you don't want to over-oxygenate someone. So you give the oxygen separately via the venturi mask. You then go for ipratropium if the salbutamol has little effect. If you do that, you want to stop any long-acting antimuscarinics that they're already on. You want to give some steroids as well, of course. Consider antibiotics. I think usually you have to meet two of the three criteria. So if they have increased sputum volume, if it's purulent, or if they've got shortness of breath, it becomes pretty obvious with someone with COPD if they've gotten that. Also, obviously, if in the X-ray you see anything, then as well. NIV. So initially you start all of this, and then afterwards you either consider for NIV or intubation, which was what this question was about. So for NIV, if after the medical treatment has all failed and the pH is below 7.35, and the PaCO2 is still raised, then that's when you consider NIV. And intubation if either the above fails or the pH is severely low, so 7.25. So in this question, the pH was above 7.25, so it's 7.28. So we should really do NIV first and see how that goes. Not everyone can tolerate it, not everyone wants it. Some people, especially if they've got severe COPD, they might have an advanced treatment plan in place anyway, so they might not even be a candidate for it. But those would be your steps that you need to consider. And yeah, hope that was clear. Any questions, of course, let me know, but I'll just move on straight to question 3. So we've got a young chap, he's 25, and he comes to A&E with this sudden onset left-sided pleuritic chest pain and shortness of breath. He's got no past medical history or anything like that. His observations are below. Then he's got reduced breath sounds and hyperresonance on percussion on the left side. Trachea central. You do a chest X-ray because everyone gets a chest X-ray, and you see that he's got a left-sided pneumothorax. There's 2.5 centimeters of air in between there. What is the most appropriate next step in management for this guy? All right, so we've got a split between B and C. Okay. So the correct answer is actually D, and I'll talk you guys why. Okay. So pneumothorax again. I think a lot of these questions are just knowing the thresholds and the guidelines and knowing the flowcharts of where to go. Luckily, if you do work in A&E, there is guidelines for everything that you can just access. Okay, so the important things to know from this question is that he's got no past medical history, so this is a primary pneumothorax, okay? And the RIN, so let's make a note of that it's 2.5 centimeters, okay? So, and he's fairly stable. So, assessing pneumothorax again, you do your A to E, and you do an imaging if you suspect it based on your examination. And then we've got this flowchart which I found from one of the trusts, which is very nice in terms of telling you what you need to do. So on the left side, we've got a primary pneumothorax, so that's when someone doesn't have any background of anything like that. Okay, so if someone has a bigger pneumothorax than a primary one, so that's greater than 2 centimeters, you want to aspirate it. Okay. And then if you so we're going to try and aspirate it. If you're successful in aspirating it, fine. If you're not successful, then you then convert that to a chest drain. Okay. If the pneumothorax is smaller to begin with, you can consider discharge, which I know some of you have put as an answer option. And then you do an outpatient follow-up as well. But that's the cutoff for that is 2 centimeters. Now, with someone who's got a secondary pneumothorax, so someone who's maybe has COPD, maybe a previous patient, we are a bit stricter essentially. So for that one, between 1 and 2 centimeters, we do the aspiration or needle aspiration. If someone's bigger than 2 centimeters in a secondary one, we go straight for the chest drain. So that's the main difference. So remember that your younger patients can tolerate more. So that's why the pneumothorax needs to be bigger in order for us to do anything. Okay, so that's why we go for a bigger pneumothorax aspiration and then chest drain if unsuccessful, whereas for the COPD patients, etc., we go straight for a chest drain if it's a bigger one and needle aspirations if it's for a smaller one. Okay. If you do a chest drain, you want to admit the patient anyway. You generally want to admit anyone who's got a secondary pneumothorax as well. I think that's pretty straightforward, to be honest. Let's go over how and where. So there is conservative management, which is fairly straightforward. Needle aspiration, there's still sort of mixed guidance on where to do it. Trusts might have specific guidance. So you can do needle aspiration either in the second intercostal space, or you can do it in the safety triangle, which is down here in the fifth and mid-axillary line. The chest drain generally goes in the safety triangle. And then after you've done it, you want to repeat the imaging to see resolution, hopefully, of your pneumothorax. Okay. Now, one thing. So the other thing I wanted to stress that what we discussed previously is not a tension pneumothorax because the trachea is central. Okay. If it's a tension pneumothorax, we want to act a lot quicker. Tension pneumothorax, you shouldn't go to imaging. If you suspect it, you want to do an immediate needle decompression. So I've got some nice pictures here. So in the second intercostal space, which is right next to the angle of Louis, you pop a big needle, the biggest needle you can find, cannula, for example, in, and then, that's it really. And then you confirm it with an X-ray usually afterwards to see that there's nothing, or is resolving anyway. Usually they need a chest drain as well, but this should take priority. And that's it. All right, question 4, speedy. So we've got a 74-year-old man. He's got a 3-day history of productive cough, fever, increasing shortness of breath. He's got a temperature, he's tachypneic, his blood pressure on his lower side, he's tachycardic, saturated at 90%. He's got bronchial breath sounds and coarse crackles in the right lower zone. You've got his X-ray on the right side, blood cells, raised inflammatory markers. What is the most appropriate next step in his management? I'm just going to split between A and C. So the majority want to do a CURB 65 score. That's absolutely the right answer. Well done. Yeah. So this is a pneumonia. You can see it quite clearly on the chest X-ray on the right side. We've got some focal consolidation in the lower zone, which corresponds with your examination as well. So do your CURB 64 score, 65 score, and then I know some of you put A, so you might actually part A is basically one of the options in the CURB 65 score. But yeah, yeah, we'll talk about. We can just try and get his CURB 64 score now. Just so we've got his 74, blood pressure is this, respiratory is 28. I don't know if he's confused. We don't know his urea. Okay, so when it comes to pneumonia, so your initial assessment should include a history. Again, you're looking out for things like cough, productive cough, fever, chest pain. Sometimes have chest pain due to the pleurisy. Sorry. You want to examine them. That will be your biggest takeaway. And if someone tells you they've got obstructive green sputum and they're shortness of breath and they have a fever, and you examine them, that's pretty much your diagnosis, pretty much spot on. You want to get the robs, very important, and we want to do some basic bloods as well. So you definitely want to do FBCs and UNEs because you want to check their inflammatory markers. You also want to check their urea and their electrolytes, generally speaking. LFTs and CRP as well. Imaging, request an X-ray fairly quickly. Then cultures, you definitely want to do a sputum culture, you want to do a blood culture if the patient is becoming septic. And then atypical pneumonia screen if you've got any suspicion. So that generally, depending on the hospital, involves pneumococcal, legionella, and mycoplasma. And then viral swabs, again, I would always do it as well on top of that. Especially in winter, there's a lot going around. People pick up COVID or anything like that very quickly. So how do we manage it? So you do your ATE first. So you give oxygen, you give fluids if they need it, and then you do the CURB 65 score. And it will also depend on how well they recover. So you CURB 65 score. So you score 1 for confusion. You score 1 if your urea is above 7. You score 1 if your respiratory rate is increased. I believe it's above 30, but please correct me if I got that wrong. Didn't really include it in the thing. Blood pressure if it drops and if the age is above 65. In terms of what to do with the CURB 65 score, so 1 and 2, you can consider discharging. 3 generally needs admission, and 4 and 5, you should consider admitting to a high intensity setting. But it's always a guideline. So if someone is like on the bloods are fine, but then obviously they need oxygen, you're not going to be, and you can't wean them off, you're not going to be able to send them home. So it's more of a guidance, really. So you're going to give them antibiotics, IV or orals, whatever they need. Give them analgesia if they need it as well. They often come with pain, and the pain will prevent them from breathing. So analgesia is very important. The majority of patients, especially the ones over a certain age, will need a repeat X-ray in 6 weeks, I'd say. So after 4 weeks, you should be resolved. So in 6 weeks' time, and the GP can follow that up. In terms of counselling your patients in pneumonia, some people think of pneumonia as just a bit of in later in terms of a chest infection, but it's actually quite severe. So even young patients will have quite significant symptoms for some time. So you can tell them what to expect. So you can tell them that in a week their fever should resolve, in around 4 weeks their chest pain and sputum production should have substantially reduced. And then the cough can be quite long lasting, and the breathlessness as well. It takes roughly 6 weeks. In 3 months, most things should be gone, but they still might be tired. And so in 6, essentially the recovery period is for up to 6 months. So that's quite important to tell a patient if they're sending home, because they need to know what to expect, and they also need to know when to come back when things are not going the right way. So make sure they get enough time to recover themselves. It's really important. And yeah, choice of antibiotics depends on allergies, depends on where you are. Use your local guidelines. Tends to be penicillin based if they don't have any allergies. Yeah, that's really it. Okay, let's move on to question 5. So we're pretty good on time. So we've got a 60-year-old man. He's got progressive breathlessness and non-proliferative cough for 2 weeks. He's got a history of heart failure and he's a current smoker. He's got decreased chest expansion on the right, stony dullness to percussion, and reduced breath sounds on the lower right leg zone. You've got his chest X-ray, which is not a surprise. What is the most appropriate initial investigation to determine the cause of this X-ray? I've got some answers trickling in. There seems to be a consensus that B is the right answer, which is absolutely correct. So yeah, so this chap's got a pleural effusion, a right-sided pleural effusion, which we need to know why, essentially. And the first step to knowing why he has a pleural effusion is to know whether it's a transudate or an exudate. And you do that by getting a sample of the infusion. So you do that by getting an aspirate. Okay, so let's talk a little bit about pleural effusions. So you get this fluid, so you got a really nice diagram that I found where you get this excess fluid around in the pleural space. What it presents with is trouble breathing, of course, a cough that's dry, it's not going to be productive because there's no infection, and a sharp chest pain with inspiration, so pleuritic pain as well, because it irritates the pleura. You've got transidative versus exudative effusions, and I'm sure you guys would have heard and learned about this in exudate. So transitive is essentially an imbalance of the pressures in the pulmonary artery, so you get this fluid seeping out to the pleural space. Okay, in exudative effusions, you have an inflammatory response which causes an increased capillary permeability. So the fluid that's going to leak into it is going to be rich in protein and LDH as well. Okay. So there are other things that you might see, which is not really what we're worried about. Sometimes you have a hemothorax, which is blood. Sometimes you can have an ampyema, which is infection, so it's going to be very purulent. And then a chylothorax, which I've never come across before prior to this. But it means, just forget it, I would say. Don't worry about that one. So yeah, how do we figure out if something is transitive or exudative? We take an aspirate, and then we look at most likely light criteria. So generally speaking, you look at their protein. If their protein is very low, you're thinking transitant. If it's very high, so above 30, you're thinking exudate. Especially in the room between, you might need to calculate, or you should definitely calculate Light's criteria in the first place. So Light's criteria, did I have a picture? No, I don't. So it's down there. So it looks at your protein ratio from serum to fluid. It looks at the LDH ratio, things like that. And then depending on, so exudate, you're going to have more protein. In transudate, you're going to have less protein LDH. Okay. And the cutoff, generally speaking, is 0.5 for the protein and 0.6 for the LDH. So yeah, different causes are also in this lovely diagram that I found. So your transitate causes are things like heart failure, hypoalbuminemia, nephrotic syndrome, cirrhosis, and malnutrition. Okay, so your accident are more the inflammatory processes. So it's going to be infection, it's going to be autoimmune, it's going to be a cancer, it's going to be a hemothorax, lymphatic, a pancreatitis, everything that causes an inflammatory response, essentially. You're going to have an exudate, okay? Especially important because of the cancer bit here. Okay, I mean, okay, all the other things are important as well, but the cancer is very important to exclude if you get an exudate, okay? So you do this first, you do the aspirate first, and then once you put it down into two different categories, then you can look into what exactly how would you further investigate it, basically. Okay. So yeah, if you get someone with a pleural effusion, you get an X-ray first. Generally speaking, you're gonna aspirate it. Depending on the volume, you can also put in a chest drain. The tap is to ascertain the cause, and then you treat based on the suspected cause. So, for example, if there's an infection, we're going to give antibiotics. If they're overloaded, we're going to do diureses. If we think there might be a cancer, we might need to do further scans, etc. Yeah, I'm speeding through it, sorry. But yeah, that's that pretty much. Let's go to question 6. We've got a 38-year-old woman. She's got, again, sudden onset pleural chest pain and shortness of breath. She is a known asthmatic and she's tried to use her inhaler, but it hasn't really helped her, unfortunately. So her heart rate's elevated, her respiratory rate is elevated, blood pressure is stable, what I would expect of her. Oxygen generation's at 94%. ECG showing signs of tachycardia. You examine her and you can't really make out any major signs on examination. What is your most appropriate next step in management? Trying to find a poll. We've got C. B. Got an E. Good, yeah. I think all very reasonable, but remember if you single best answer, it's the most correct one. So it can be sometimes very tricky to be super correct. Right. So the correct answer is, well done to the people who got that one, is B. Okay, so we'll talk about what's happening with this patient. So we've got a known asthmatic. So I tried to throw a little bit of a curveball there. Who's shortness of breath, and he's got some chest pain as well. Now, it's somewhat suspicious of an asthma exacerbation as well. I give you that. However, I tried not to throw in too many things. So she's not wheezy. You examine her chest. She's fine. She's also got this chest pain, which is quite untypical for someone with asthma. Really, it's more chest tightness as opposed to chest pain. But also, the most important thing is that her salbutamol inhalers have not really helped her. So especially with this, you always need to consider other options. Now, whether that is the diagnosis is a different question. But if someone is not responding, has chest pain or shortness of breath, and is not responding to something that you think might be on, always reconsider your diagnosis. So in this case, you have very little to go on. But if someone has shortness of breath, very sudden, something that should always be in your mind is a PE. PEs, they can present in anyone. And often the main things that they present with is shortness of breath and tachycardia as well. The oxygen saturations are on the slightly lower side, not dangerously low, but given that she's breathing quite much, I don't expect them to be at 94%. So there's something going on. And also she's quite young as well. So if we think about her well score, right, yes. Yes, we'll talk about that in a second. Yes, so if we think about a well score just well, we have to question up as well. So well score, you can, again, you can put it into anything that you want, really. Because if you think that PE is a most likely diagnosis, you score 3 points already. And then tachycardia will give you an extra 1.5 points, essentially, in this case. So we'll meet the threshold. Okay, so we think this is a PE, basically. So we think that it's at least equally likely to be in the most diagnoses, and we've got a heart rate of it. So we've got 4.5 of a well score, okay? Now, if you have to, before you know that this is a PE, you kind of have to treat it as one. So if they're hemodynamically unstable, you would consider thrombolysis immediately. Okay, so that's not a problem. In her case, her blood pressure is actually holding up quite nicely. So we're not quite there yet, but we need to keep a good eye on her. Well score. So if it's more than 4, a PE is very likely. Okay, so you want to do an urgent CTPA scan. If, for example, they've got a contrast allergy, you can do a VQ scan. That's second line. Now, if your department, for example, if your hospital only has one CT scanner and that has a tendency to break, like my hospital does, and there is delays, so there might be a whole day where you don't get a CT scan, and the next hospital is further away. So if that's the case, you might start to treat them on anticoagulation in the meantime. Okay. So that, I guess that would go into your question, saying it's like, yeah, that's, how to put it? Yeah, I mean, the thing is, so it's a good question. It's slightly different. So definitely, if it's a high risk PE, as in someone who's hemodynamically unstable or high risk of deteriorating or not making it to the scanner, if you think that they're going to crash, then you should treat. So sometimes what people do is they sort of give a half dose of thrombolysis as well. We had a big PE this week, which we actually sent to the scanner with alteplase ready to thrombolyze them if anything needs to happen, if they arrest in the scanner. Okay, but if you can get the patient to a scanner, and usually the department is very quick in prioritizing this patient, you should try and get them to a scanner. Okay. If obviously not, we go to thrombolysis. Sorry. I hope that answers your question. That sounds just slightly different compared to the testicular torsion that you suggested, because the main thing we're worried about is the main thing to determine which way to go is if the hemodynamically stable or unstable, if that makes sense. No worries. Just cover if it's 4 or less on the thing, then it's basically not likely. You can do a D-dimer. D-dimer, again, is not specific, but it will give you a good shout. If the D-dimer is positive, you can then go for the scanning again. If it's negative, consider alternative diagnosis. If your results are delayed, you might anticoagulate them if there's no other further complication, no further contraindications of that as well. Remember your contraindications to thrombolysis as well. So if there's any risk of bleeding, essentially, you might not be eligible to thrombolyze them because the risk of bleeding from that is very high. That's ultimately a decision, thrombolysis, that has to come from your senior. It will even often be the on-call consultant, actually, and that might be involved in the planning as well. So yeah, I think we had a patient who had a really massive PE. She was quite unwell, and she was considered for thrombolysis overnight, but she didn't get it because she's had postmenopausal vaginal bleeding. So they put that as a contraindication, and she didn't get thrombolysis. So there you go. All right. So I've put a nice. This is a massive PE. Hopefully you guys can see that. So you can see this is a nice labeled diagram. So you've got your arteries and you've got your pulmonary arteries there. the white thing here, and then you can see this kind of dark and shadow, which is a filling defect across. So this is called a saddle-shaped PE because it sits over where your bronchi bifurcate over the carina, so it sits over there. Not a good sign. Patients with that one are usually a lot very, very unwell, and might need thrombolysis. Anticoagulation choices, usual. So apixaban, rivaroxaban. You can also do low molecular volt initially if there's any contraindications for that reason, and then switch. So you do 5 days, I believe, for bridging, and then you do dabigatran. Further investigations that you can consider, and sometimes AME are very good at, is you want to do an echo. Bedside echoes are very good. They're very quick. Seniors are very good at doing it because you want to see if there's any evidence of right heart strain. Clotting, very important. And then, so that's quite acute. And then also, once you've stabilized your patient, you want to do malignancy screen, very likely, because you need to figure out why they've clotted. And malignancy is one of the key things to rule out, really. Of course, check for other risk factors, any travel, any clotting medication, COCP, whatever, and things like that. But malignancy screen often, so they'll often have a CT, chest, abdomen, pelvis, if they've not had any scans yet, just as a baseline screen to rule out anything. Okay. All right. So this is what I am kind of split it into half roughly. So breathlessness, just to summarize. So you get your respiratory causes, so asthma, COPD, pneumonia, PE, we covered, pneumothorax, we covered, pleural effusion, we covered. Don't forget your cardiac causes as well. So you get things like edema, ACS, tamponade, arrhythmias. And then usually if it's, so other causes would be things like anemia, DKA, sepsis, and anxiety as well. Anxiety, please let it be at the bottom of your differential list. It's not life-threatening. So yeah, that's how you would target this. And now let's move on to a little bit more of chest pain, just briefly. So chest pain, fun things. So we've got a 68-year-old woman. She's got a 2-hour history of chest tightness radiating to the jaw. She's got nausea and she's sweating. She's got a past medical history of hypertension and CKD. Takes ramipril and amlodipine. These are OPS. ECG on the right. Sorry, it's a bit small. I hope you guys can still somehow make out something. Her initial trop is 58, and her GRACE score is 128. How would you manage this lady in ALE? And this again, just knowing your flowcharts. I'm sure you guys can make the diagnosis fairly quickly. You've got a split between D and E, which is excellent. Those would be your main ones. That. Okay. So what do we have? So we've got something very suggestive of ACS, right? So we've got chest pain, cardiac sounding chest pain because it's radiating. She's got nausea. We also know her trop is raised, and we've got an ECG. ECG, generally, so what I remember from the ECG that there's no ST elevation, but we've got some ST depression, specifically in leads. Was it 1, 2, 2, 3, AVL, AVF? Yeah. Oh, I really can't make it out. Anyway, just take my word for it. Yeah, perfect. Thanks. That's the thing with using PDFs here, honestly. So we've got an NSTEMI. Now with NSTEMI, this is where I put the grey score down. NSTEMIs are not as straightforward as STEMIs are. So yeah, again, knowing the threshold. So Sumi, you got that completely right. So for an NSTEMI, in her case, with that intermediate risk of a grey score, we start aspirin and fonopionex, and you want to arrange for an inpatient coronary angiography. Okay, so yeah, we'll just talk through the options. It's a nice floating chart, basically. So in any ACS, you want to give them a loading dose anyway, of 300 milligrams, and then they will be on aspirin 75, lifelong usually. So you give fonopionex unless they have PCI. And then you first usually calculate the grey score. So the grey score, I've got a copy at the bottom. So in just worth knowing roughly the thresholds. So high is above 140, low is above below 108. So we're kind of with 1 to 8, we're in a medium category. Intermediate to high, you both offer angiography plus minus PCI. Usually, if they're unstable, obviously you go immediately. If they're stable, you can do it within the next 3 days. If they're low risk, you don't offer angiography. You just start them on tigerol or clopidogrel, depending on the bleeding risk. What other things you need to do? So you need to assess their systolic function. Yeah, to see if there's any complications from this. And then what else would you do? You would do your cardiac rehab and secondary prevention later down the line. So that's mainly. Do I have? I thought I had a flowchart somewhere. No, I don't have a flowchart. There's some great flowcharts around that I looked at that you can consider into it, but I kind of just condensed this one down into separate things basically. If you had a STEMI, so just to go over this as well, very similar. So you do your loading dose, and then can we give PCI essentially? If we can give PCI, how quickly can we give it? If it's within 2 hours, you do that, and you do a further anticoagulation. If you can't give PCI, you can do, but it's still within 12 hours, then you can do fibrinolysis, antifermin, and another anticoagulation. If the onset is greater than 12 hours, you give, again, one of the other anticoagulations, so tigerol or clopidogrel. Again, it's just worth thinking really which ones to give in what circumstance. It's a bit confusing. Not sure why they're different, to be honest. It's just the data. Same thing, you want to get an echo done. So that's usually something I would request fairly early because they take time to get done. Cardiac rehab and secondary prevention, like with all of our usual ones. So that's the main thing. Yeah, I think that's it. Yeah. So it's just STEMIs, I think, are more straightforward, which is why I chose an NSTEMI for that question. Knowing what to do based on your grade score and an NSTEMI is very important. So knowing where to go. In reality, you will have a nice guidelines and you look at the guidelines, but for exams, you're going to have to know it by heart, I'm afraid. All right. Oh, gosh, sorry. Yeah, that was a bit of a mistake, wasn't it? Fine, let's talk through it and you guys can vote regardless and hopefully get 100% on that. We've got a 64-year-old man, sudden onset severe tear and chest pain. He's got a history of poorly controlled hypertension. He's very anxious. He's sweating. There's a difference in his blood pressure from his left to his right arm. ECG shows no specific ST changes. X-ray reveals a widened mediastinum. What investigation would you do to confirm what this is? We put up the poll quickly. And you guys probably saw, but maybe some of you won't. Yeah, you guys probably saw what you would do, but just tell me. Okay. So some of you got it correct. Well done. So, yes, what do you think? So any chest pain that's radiating to the back, we're worried about a dissection, okay? So those patients will have their scans actually fairly quickly. So even on triaging, they will have their scan probably before they get seen by anyone else. So, and then the question is what scan? So remember that we are looking at your big aorta. We're not looking at your heart coronary vessels, okay? So the correct answer is a CT angiography of the thorax, because you want to get your ascending and your descending aorta right to your thorax down, okay? Coronary angiography is to visualize the blood vessels supplying the heart, which is not quite the right thing in this one, okay? So yeah, well done for those of you who got it right. And also, I acknowledge they've got confusing names, so they're very similar sounding. Yeah, main things I think from the question are just difference in blood pressures, radiating to the back, and he's a bit unwell. X-ray findings, again, you can see that depending on, usually you wouldn't really go to an X-ray. If you suspect it, you'd go straight to CT. You don't wait for this, but this is what you would see, a widened mediastinum. Okay, so yes, so we talked about severe chest pain, may radiate to the back. They could have risk factors, so poorly controlled hypertension, like in this guy, and Marfan's examination, pulse difference. You might hear a diastolic murmur, and then ECG. You can do a quick ECG. ECG is anyone gets it. Draw a STEMI just in case. Probably want to do some bloods as well, including a trop to make sure. When you do your bloods, just do a full set and make sure you do a group and save as well. And the blood gas to see what the hemoglobin is doing. And then imaging, generally speaking, a CT will be better. You can do a TTE as well, or a chest X-ray, but your CT are going to give you the better imaging, basically. There's another great flowchart I found, depending on what to do. So you guys know that with aorta dissection, there's two different types. There's A and B. A is for your ascending aorta. B is for your descending or below aorta. Okay. So generally speaking, if someone is unstable, like if their blood pressure or systolic is dropping, and you've got to confirm that there's a dissection, you give them surgery regardless. If they're somewhat stable, but then you figure out it's involving the ascending aorta, you still put them to surgery. Then if it's involving the descending aorta, and then you look at their complications. So things like that. So it would be, has it ruptured? Are they being malperfused? Or is there any refractory pain? And then you basically go for surgery if any of those have happened. If it's uncomplicated B, you optimize the medical management first, but then you might still take them for surgery is the ultimate thing, but you want to do medical management first for those uncomplicated descending aortas, aorta dissections. Okay, I think that's all you need to know, to be honest. Speed of time, I'm going to move on. So just quickly, got question 9. We have a 20-year-old guy. He's got sharp central chest pain that worsens when lying flat and improves when sitting forward. He's recently had a viral upper infection. You listen and you hear a high-pitched scratching sound on auscultation. You got his ECG down there. Again, it's really small. I apologize. Given the most likely diagnosis, what is the most appropriate first-line management for this chap? Now, I think hopefully you can still make out some of these ECG changes. So we've got some ST elevation in some of the leads. In a lot of the leads, to be honest. So I can see it in 1, 2, 3, AVF, probably 3, 4, 5, and 6 as well. Okay. Oh, very even split. Okay, fab. Right. So in terms of diagnoses, so especially with this widespread ST elevation, a recent recovery from an infection and you hear a scratching sound, you are thinking of you're thinking of pericarditis, okay? With pericarditis, the first line management is C. So well done to Simi, you got that correct. Yeah, let's quickly talk about what it is. So with pericarditis, history is very important. So risk factors, things like recent cardio surgery or illness. You will hear the pericardial rub, which I described in this question scan. You still want to make sure that they don't have ACS. So you want to do an ECG, a troponin. You want to do a chest X-ray and echo probably as well, just for completion. Your ECG is going to show you most likely widespread ST elevation. Trop, yeah, something. So, and then, so this is, I think this is the X-ray that, the ECG, sorry, that I showed. So you have your sinus tachycardia. So you have this kind of concave ST elevation with a PR depression. And then in your reciprocal leads, you're going to have an ST depression as well, which you can see here in V1 and AVR with a bit of a PR elevation as well. So yeah, widespread ST elevation, concave shape, generally speaking, like this, it's quite suggestive of pericarditis essentially. When it comes to managing it, generally speaking, you want to figure out why they have it, but you give some NSAIDs and colchicine unless they have TB suspected or confirmed. And then a PPI, of course, as well with that. You can consider steroids, restrict their exercise depending on if you're an athlete or not, it takes longer or shorter. I think athletes have to be off the training program for at least 3 to 6 months. You want to treat your underlying cause, so if there's an infection, you want to treat the infection. Other causes could be surgery, autoimmune disorders, immune processes, drugs, cancer as well. And then if someone has purulent pericarditis, so that one, for example, you can either suspect it or if you do a TAP as well, you need to start them on broad spectrum antibiotics and have specialist input. That's all I could find from the CKS guidelines, really. Just to keep in mind that this one's slightly different. Okay. Let's whiz through our last question quickly before we guys go for break. So we've got a 72-year-old guy. He's got palpitations, shortness of breath, dizziness. Heart rate is fast, regular. ECG shows new onset AF. He's stable. He's got no other signs. He tells you that he knows quite well. This started 8 hours ago. He tells you exactly what he was doing, and then he felt the palpitations. What do you do with this patient? Forgot to pee. I actually realized I made a bit of a mistake with this question, but yeah. But you guys still got the correct answer, so I didn't make that much of a mistake, obviously. But yeah, just to keep it in mind as well. So yeah, you guys are absolutely right. So we're going to go for a control, which probably should have been a rhythm control. Now looking at the question back, but yeah, let's talk about it. So with AF, history usually involves palpitations of some sorts. Examination, you're going to have an irregular pulse, very likely. Investigations, so you see your ECG here, so you can see no P waves, and it's irregular rhythms. There's absolutely no pattern at all. you want to do your bloods because you want to figure out why have they started to have AF. So things like electrolytes, thyroids, things like that are very important. Clotting as well. You can do an X-ray because everyone gets a chest X-ray and an echocardiogram as well to figure out what's going on with the heart. Now, this is where I was saying I realized I made a bit of a mistake because I was thinking I'm making a short, a short onset, but it was too short. So, generally speaking, if they're unstable, you're going to convert them no matter what they do. Equally, if their heart rate, or if they've got broad QRS cox and the heart rate is fast, you might think of DC cardioversion as well. Okay, so now if they're stable and they've got this fairly new onset, it depends on how long they've had it. So in our case, we actually should have gone down the rhythm control path because they've had it for 8 hours, which I said. So you can rhythm control them. If they've had it for a longer time, you go for rate control first, and then you can do rhythm control as an outpatient once they've been anticoagulated for a while. Okay, so the reason for that is that with AF, we get a risk of clots, right? And once you cardiovert someone, you get a risk that the emboli that have formed go straight to your brain and you get a stroke. So it's just a risk-based strategy that if they've not had it for a very long time, the risk of that having already formed is very low, so you can safely cardiovert them. If it's been over 48 hours, you want to usually wait, make sure that they anticoagulated before you attempt to do that, unless they're unstable, of course. So yeah, in the state of mind, we'll just pretend that I said this was 48 hours. And then you guys would have been absolutely correct with your rate control and things like that. What's some other things to think about? I think that's pretty much it. I think those drugs, just knowing kind of you can know about this. You can electrically cardio about someone. You can. That's pretty much your management of AF. Yeah. Any questions, guys? I'm quite where I ran over a little bit, so I'm just gonna go to our next slide. Oh, okay, fine. Chest pain, all of those causes. So cardiac, definitely make sure to exclude ACS, dissections, things like that. Remember your respiratory causes, which we already covered, like PE, thoraxes, things like that. Can also be things like gastro. Gastro presents quite similar. And then MSK as well. All right. So yeah, what's happening with my things? Let's go for a break. I would suggest any questions. Let me know in the chat. And we'll be back in 5 minutes. So let's make it 12 past. 12 past. So I'll put the things in the chat. There we go. We'll be back at this time. Get yourself something, and we'll see you shortly.
Hi everyone, can you see me? I hope that was long enough for a break. Right, well, we'll just we'll make a start. I think there was another third person, hopefully around. So feel free to have a go. I think one of us will be putting up a poll as we go along. Okay, so the next section, the next lot, is based on ED presentations using ATLS principles and a bit about sepsis as well. So that's quite broad. So if you try and gauge your brain into sort of like trauma mode, usually for the ED things, and then we'll go into sepsis as well, because that's also a really big presentation that comes up commonly. I forgot to introduce myself. My name's Dee. Full name's Deep Shika. Nice to meet you all. So question 11. You've got a 25-year-old male who's had a gunshot wound to the abdomen. He's taken straight to theatre from the ED due to hemodynamic instability, and he's got a positive FAST scan. A FAST scan just means a point of care ultrasound, so you get like a POCUS, but it's done really quickly, basically, in ED. Intraoperatively, there's a large laceration to the right hepatic lobe, involving the inferior vena cava, and resultantly, there's a massive bleed. So, what's the most appropriate initial strategy for managing this blood product replacement? Just try and think of, usually with anything like this, with ATLS or trauma, you think of C, A, B, C, D, E. So you've got C, catastrophic hemorrhage, then A to E is the normal things. Okay. There's also a big C, which is catastrophic, and then there's little c, which is cervical spine stability. So everyone's just gone for, I'll give it a few more. Okay. It's a hard one, because they all kind of sound right, don't they? But you've got massive bleed, major hemorrhage, which is what you're meant to extract from this question. Is that everyone who's voted now, I think? Give it a few more, and we'll go through it. Right, I'll go through it. So next slide. So the correct answer, oops, sorry. If you go back, I don't think I put the correct answer. The correct answer is C, however, so it's 1-to-1 of each. So a bit about transfusion and major trauma. About 39% of trauma-related deaths is due to hemorrhage, i.e. hypovolemic shock or hemorrhagic shock. Okay, and then about 2% of those will then require a massive transfusion. So a massive transfusion is, every time you are concerned about it, the first thing to do is, instead of calling 2222 and you go like crash trolley, you go 2222 and you say into the phone, can I set off the major hemorrhage protocol? Okay. And that will set it off. They will automatically call the blood bank. So it's defined as a replacement of the patient's entire blood volume within 24 hours. You've got about 5 litres of blood within you. Okay, it doesn't take a lot. I think it's sort of 500. If you sanguinate that much, that would classify as, like, is it type 3 shock? So more than half of the estimated blood volume is transfused in 1 hour. Early intervention is really important. So as well as replacing, you're going to try and give them tranexamic acid, so it should be given as early as possible. It's an antifibrinolytic, so wherever the source of blood is, you want to promote some clotting, and that's more important than being concerned about like clots later on, if that's what you're thinking. There's a really good CRASH 2 study which showed reduction in mortality when TXA was given within 3 hours of injury. So there's an argument, one would say, that pre-hospital medicine should also be trained in giving TXA. So paramedics, when they're fine, because by the time you come in, it might, you might have lost like an hour or a half, or depending on where the patient has been found, right? So yeah. And then hemostatic resuscitation, so practice of transfusing blood in fixed ratios to prevent coagulopathies during massive bleed. So that's why you give fresh frozen plasma, platelets, and packed red cells. So it's 1-1-1. Okay. And that means that you're addressing the blood loss, but also maintaining the clotting function as well at the same time. And you're giving the TXA, if you remember. So yeah. Next slide. So the main target. So once you've initiated all that, how are you going to know that you can stop and you don't need to keep on giving? So there's some target parameters. That's evidence in that paper on the bottom left corner. So you're aiming to correct physiological derangements, aiming for hemoglobin of 80 or 80 to 100. So that's put in deciliters, but if you've got different measurement in your hospital, platelets of more than 100. You want the INR to be less than 1.5. So you'll remember, like if patients going for surgery, you've got those parameters of, what should the INR be, and basically anything above that, that's you still need to replace. You want the pH, so you want the pH to be normal. Strangely, when you have, well, not strangely, it does make sense, but when you have hemorrhagic shock and blood loss, you become really acidic. And you want to make sure that the patient is adequately warmed. So you'll know that when you check, if you've been replacing it properly with transfusions, that the temperature will start rising up again. I think it's the next question now. So this is my favourite topic. Love it. Right. 24-year-old man presents to ED after being punched in the face after an altercation. He's alert but in pain. He's got noticeable facial swelling, bruising around both eyes. There's some mid-face mobility. There's bilateral ecchymosis, i.e. bruising around the eyes. The entire maxilla is numb, and the nasal bridge appears really flat. Which of the following clinical findings is least likely to be associated with this type of facial fracture? Just testing your anatomy a little bit. Least likely. So most of them will be affected. Which one doesn't marry up? And if you don't know, sometimes you can do it by exclusion. Like if you think the other ones, you're like, yeah, you'd get that. I'll think of the one that you like, that doesn't make sense, or I don't know what that is. Okay. Is that everyone? I think. Is everyone voted? Hopefully. Right. We'll go through that then. Next, yeah. So the answer is paresthesia in the inferior alveolar nerve. The inferior alveolar nerve is in the mandible, not the maxilla. Okay. So a bit about craniomaxillofacial injuries. Most commonly due to fighting. The most common bone, if anyone asks, is the nose, followed by the cheekbone, the zygomatic bone. But in the case that we've just been through, it's talking about Lefort fractures. The reason it's really important to know that in A&E is because you'll get a lot of people with facial injuries after altercations. you're fine picking up, the little bits, you've got an orbital floor or a mandible or a cheekbone in isolation. But Le Fort fractures are the things that you don't want to miss and you want to manage correctly. So Le Fort, it goes. I won't read the slide. You can read it in your own time or while I'm speaking anyway. But simply put, a Le Fort one clocks off the maxilla from the base of the skull, right? But the base of the skull is intact. So this maxilla bit moves. And if anyone's ever had any surgery called orthognathic surgery, if you've got like a strange bite, they do that on purpose. They give you a Le Fort 1 fracture in the operation. Then you've got Le Fort 2 fracture, which extends from like the nasal bridge, passes through the frontal process of the maxilla, so all the way down here, involves the orbital floor and the rim, and travels underneath the zygomatic bone. So that's Le Fort 2, and you can see the prevalence of it decreases the more complex it is. Le Fort 3 is really bad, right? You don't want that. That's the one where you're basically a base of skull, and you're worried about panda eyes, which is what they're talking about in the question, periorbital ecchymosis. So the main thing, from a safety perspective, is these patients might be bleeding a lot, because you've got the I think it's the maxillary plexus behind, and then you've got the internal carotids going up into the base of skull, so they can start bleeding profusely, or a branch of the internal carotid. Sorry. In these cases, it's really important that you impact the fracture up. So someone puts their hands underneath in like this, and you shove it up basically, because if you let it hang, it's just going to bleed profusely from the nose, mouth, like everywhere. Well, from the nose, and then it'll go down into your oral cavity, and then you'll be bleeding out, and then there's a risk of aspiration and airway loss, and then it becomes very complicated. So you want to make sure that it impacts, and you have called the maxillofacial surgeons really quickly, you call the anaesthetists really quickly. Really important in all of these cases to make sure that you check with those surgeons whether it's safe to put an NG at any point, i.e. like before surgery, if you stabilise them and they need an NG, because you don't want to go up into the cribriform and into the brain. Okay. So a bit more about other types of facial injuries. I've divided them up into ocular. Technically, retrobulbar should be an ocular, but it's a separate column. So you've got ocular injuries, nasal injuries, retrobulbar hemorrhage. I'll go through retrobulbar hemorrhage because that's the one you definitely don't want to miss, because you've got, I think, 100 minutes before you lose vision from injury. So from injury time, if it's going to happen, it's going to happen most commonly in the first 100 minutes, which is where you're getting, it's compartment syndrome of the eye socket, essentially. You'd think that the eye socket's open to the rest of the world, like here, to the air, but because you've got the globe there, it stops anything that's happening behind the eye coming out. And the problem with having any clot or any pressure or anything like that happening is that it'll push the eyeball out, and the optic nerve will get stretched, and then it's the stretching of the optic nerve that knackers it, and then you lose vision. So you want to assess for like pain. It's usually really sharp. You get proptosis, you get pupil reactions or loss, so you'll get like a RIPD. You get paralysis, and they won't be able to move the eye, and you can lose visual acuity. So the really good test in ED is like a tip of a red pen, and ask them to close each eye and ask them if it looks as rich, like the colour of the redness looks as rich from one eye compared to the other. And it's very common in Le Fort type fractures. The treatment is something called a lateral canthotomy, where you've got lateral superior and inferior ligaments, like behind, sort of here in the corner, and you want to. Every ED doctor, I think, gets trained in it as well. But essentially, you get a needle with some local anaesthetic. You point the needle that away from the eyeball, and you put some injections in and numb it up, and then you get pair of scissors or crimpers. Everything you do, you point away from the eyeball itself, and you're shoving your instruments in the corner of your eyelid and crushing it, and then you reach inside, and then you point your instrument, your scissors, up and down and cut the ligaments, and then that releases a space, and the blood from behind the eyeball comes rushing out. It's a really good skill to learn if you're ever placed in ED. So definitely get onto some like simulation trainings if you can help it. Nasal injuries, most common. Ensure that they're not new, and ensure that they're new and not an old deformity. So ask them, is there any change to the shape of your nose from before you got punched, as opposed to, does your nose look wonky to you? Because if they've been in fights before, and the common thing with these patients is if they've been punched before, they've got a personality that they're probably going to get punched again. So it's really important. If you're getting epistaxis or any runny type of nose, you need to figure out the quality of it. Is it blood? Is it blood mixed with something clear, or is it clear? And if it's anything of this latter two, you're worried about CSF leaks, and then you want to rule out a base of skull fracture. So it's a very common like PASMED question type thing, isn't it? Panda eyes, but you also want to look at battle sign, which is on the mastoid area. And if you're going to offer fixation of the nasal bone fracture, you make sure that they have an ENT review within the week, because the window of operating on it is about 10 days. Some people can manage it just a bit of gas and air. Some people need a GA, so if you get them a follow-up within the week, it covers them for both eventualities. And then orbital floor fractures. So there's two types. One's the orbital fissure syndrome, which is when you get force to the lateral orbital wall, so like this bit, which is the frontal and zygomatic bone suture here, so that can get punched. And with that you get things like lack of eye movement, drooping of the upper eyelid, RAPD, loss of corneal and accommodation reflex, and then you get a numb forehead in that area. And the second one is an orbital blowout fracture, which is you get a straight on punch here. The rim might be intact, but the orbital floor is like an eggshell, if the rim's really strong and you punch it, it kind of does this, like it crumples, and then it's like eggshell, so it'll fracture, and then below you've got the maxillary sinus. You're looking like sideways on at a person. And the main thing with that is that if you get fat underneath the eye, or the muscles of the eye, so the inferior rectus drops down and gets entrapped, you can get diplopia, especially if you're trying to look up or outward. This is more, if you get that with an adult, you make a eye assessment, follow up with ophthalmology, you get them a MaxVax appointment within the week. You've got 21 days to fix an orbital floor, so it's not a major deal, but the thing is you want to get an ophthalmology assessment prior to the surgery. The really important thing with this presentation is in kids. So if you get an orbital blowout fracture, they get something called a cardio-ocular reflex. So in children who have this fracture, and then you get entrapment, it stimulates their vagus nerve, and then they feel nauseous and they get very tacky, and they might vomit. So in orbital floor fractures in pediatrics are not a 21-day kind of rule. They're like an immediate kind of situation. So you need to make sure that they haven't got this presentation. If they do, it's an urgent type of scenario, and you make sure that MaxVax come and see the patient, rule that's not happening, rule out the fact that they don't have cardioocular, and then it's back to the same adult kind of route. If they've got cardioocular reflex issues, then they need to go to theatre within the day. Next question. How do I change it? Okay, right. Question 13. You've got a 31-year-old, 32-week pregnant woman. She's hit by a car. She arrives at ED. Her systolic blood pressure is a wee bit low. It's 105, and then her heart rate's very high, so it's 126. You do an abdominal exam. some generalised tenderness, some bruising on the left side. You do a fast scan. There's no abnormalities, no major abnormalities anyway. So what's the next most appropriate step in a management? This one's an odd one because you really do just have to apply ATLS principles, sadly. Okay, I think we've got all of it. Got 2 responses so far. Does anybody else want to have a go? I'm not saying you're wrong, but maybe. So you want to think about the goal here is not just speed of imaging, because you've got an ultrasound already. Next step is accuracy. So what's the next most accurate? What's the next thing that you could do that would also give you an more accurate impression of what's going on? You have to bear in mind she's hemodynamically not great. So in an emergency, you have to also think about the speed with which your imaging is going to be carried out. And with a pregnant woman, you wouldn't want them to be... So you've got to position them in a particular way in scanners, don't you? And the shorter the scan, the better. So you've got to position them to the left so they're not compressing on the inferior vena cava. Which you can do in most things, obviously, but one of them's a bit quicker than the other. Right, we'll go on to the next slide, which is the answer. So it's arrange an urgent abdo CT scan. And that's for the reasons I was mentioning earlier. It's quicker than an MRI, and it's more accurate than an ultrasound. The fast scan is a type of ultrasound, so you're not going to gain a great deal more with a departmental ultrasound. But I can see why you went for that. Right, so this is just a table going through some of the imaging that you can do in pregnant trauma patients. So you've got the fast scan as the initial kind of really quick. Some places they also have it in the ambulance, so you can do it on scene. You can also do an ED resus, and then you've got the CT scan, and then some aspects about radiation consideration, especially for patients who are really concerned about it, or if you yourself are concerned about it. So fast scan or ultrasound obviously avoids any ionizing radiation. Sensitivity is about 90% in the first trimester, and then it goes down obviously as you go along in your pregnancy, just because there's so much more mass for the sound waves to penetrate through. So your accuracy of what you're going to see is going to reduce as the pregnancy goes on. So obviously got no radiation risk. And then CT scans are first line in major trauma with anything about a suspected visceral injury. So if you know in a question or a scenario that an ultrasound's been done, quickly just move on next to the CT scan. It's the most sensitive of visceral injuries. The fact that she's got generalized tenderness, it feels vague, it feels non-sinister, but it is concerning in a major trauma, because you're like, well, why she got generalized tenderness? You know, is there something going on? Has she got free fluid? Or she's got an abruption. So it's the most sensitive. you still use it basically despite the radiation risks, because it's just crucial to get the diagnosis correct in the first instance. You've got some risks in early exposure due to risk of like anomalies, fetal loss, and then if you have a late exposure, you've got risk of childhood cancers. But the key is always to save the mother, because if you save the mother, you save the child. If you save the child, it's pointless, because if the mother dies before delivery, like the child's not gonna survive, right? So that's a really important thing to get your head around with ATLS. You major trauma, pregnant, save the mum, because then you will save both. Right. Next slide, please. So the next question, another trauma one. So a 30-year-old man brought to ED department after a motorbike collision. He's alert and complains of severe neck pain and weakness in all 4 limbs. So cervical pain, quadriplegia, and on examination he's got reduced power of 3 out of 5 in both upper limbs and lower limbs. He's got a poor sensation, diminished pinprick sensation below the neck, and he can't pass water anymore. His vitals are stable. His cervical CT spine reveals a fracture at C5. Which of the following is the most appropriate initial management step in this patient? That's really good. I think if we go to the next slide, you got that right. Well done. That's really, really good. Always stabilise the C spine in any major trauma. So that was the little c, big C, little c, AT. Yeah. So signs of a cervical spinal cord injury following trauma. He's got pretty much all of them. He's got the quadriparesis. He's got sensory level, urinary retention, a classic. Although the CT does confirm a bony fracture, MRIs, you'll need an MRI later on to assess a spinal cord compression for any edema, ligamentous injury, or disc herniation, which will then help you guide like definitive management. So you want early and appropriate immobilization, which is what we've done to prevent any secondary spinal cord injury. Okay, so next slide, we're going to go through some, I think it's spinal shock versus neurogenic shock. Next slide, please. Yep, so neurogenic shock sounds like a spinal or neural problem, and it is. But essentially, it's a type of distributive shock due to disruption of the sympathetic pathway following spinal cord injury above T6. So it's very important to distinguish that it's a cardiorespiratory manifestation of a spinal cord injury, which is different to spinal shock. So you get hypotension, you get bradycardia, and you get warm, dry skin versus a cool, clammy skin that you get in hypovolemic shock. So the heart rate's low, low blood pressure, whereas in like hypovolemic, you're going to get hypotension and tachycardia. Management is you give them fluid rhesus, you give them NORAD, basically, noradrenaline, for the persistent hypertension. You give them atropine for the bradycardia. The reason you give them atropine is because it crosses over, and you give them atropine in ALS algorithm as well, but in this it's really important because atropine crosses the blood-brain barrier, and that's why it gets up into the sympathetic system, and then it works and maintain spinal precautions and airway protection. So you've got the collar, making sure you've got a safe airway. If you need to intubate, you intubate, or you get the anaesthetist, to intubate someone who's airway trained. Next slide, please. So a bit about different spinal injuries. You've got anterior cord syndrome, central cord syndrome, Brown-Séquard, posterior cord, conus medullaris, and chorda equina. We'll just go through some of that quickly. Anterior cord syndrome, often due to flexion injury, so like bending forward, or due to infarctions. You get loss of motor function and pain, temperature below the lesion. You get preserved proprioception and vibration. Central cord, typically due to hyperextension injuries because they've got lots of stenosis or spondylosis, but then they hyperextend and that doesn't do them much good. You get greater weakness in the arms and legs, and you get variable sensory loss. Usually you get lung dysfunction. Brown-Séquard is a great exam question, isn't it? You get the hemisection of the spinal cord because of the decussation, and you get ipsilateral motor loss and proprioception, contralateral pain and temperature loss. Posterior cord syndrome is rarer. You get loss of vibration proprioception. So you can learn anterior and posterior cord syndrome together, I guess. And then trying to difference between conus medullaris versus chorda equina. Chorda equina, sorry. So chorda equina, you get the low motor signs, radicular leg pain, saddle anesthesia, which we know about, and bladder retention. Urinary retention, sorry. Whereas with conus, you get mixed upper and lower motor neuron signs. You get early bowel and bladder involvement, whereas in chorda equina, if you've got bladder and bowel issues, it's a later sign, and it's a poorer prognosis if you've got bladder issues with chorda equina. Right, I think in the interest of time, I'll move on. Next slide. Thank you. So this question is testing your assessment of how to classify sepsis, essentially. So you've got a 68-year-old woman, type 2 diabetes, CKD3. She's got a 2-day history of malaise, dysuria, confusion. She's quite febrile, hypotensive, tachypneic. Pulse is 98. It's not terrible. And she's saturating 96% on air. Blood glucose is 11.3. She appears quite drowsy, and she's got suprapubic tenderness. So we're not trying to figure out where her infection is coming from, but it's about whether you know which bit supports the diagnosis. So we'll just wait for one other reply, and then we'll go on to the answer there. Okay, next slide, please. So whoever said infection with acute organ dysfunction is correct. Sepsis is all about preventing organ dysfunction. Okay, next slide, please. So so according to the Sepsis 3 definition, which you can read about in, I think, BMJ, it's a life-threatening organ dysfunction caused by dysregulation of the host response to infection. So this patient, for example, has got suspected UTI, and then she's got AKI on top of CKD, and she's got altered mental state and a raised lactate. If you probably look at her using these, she might have a high urea as well. She'll be she might be uremic. So why others are incorrect? So these are part of the SIRS response, but they're quite outdated and not sufficient for sepsis diagnosis alone. Raised lactate is not specific enough, and whilst like the hypertension suggests poor perfusion, it's not in themselves like diagnostic of sepsis. Confusion and raised inflammatory markers are supportive, but again, not sufficient. So we'll go on to the next slide, which goes into the SOFA and the QSOFA guidelines. So that behemoth table on the left is the SOFA criteria. And the goal of it is essentially to get early identification, because the earlier you pick it up, the earlier you start treating. And you need to have two criteria. You need to have the presence of a known or even a concern about infection, and you've got clinical features that point towards some sort of organ dysfunction. So in that patient's got renal dysfunction there. You need to calculate the SOFA score. What it tells you is quantifies the level of organ dysfunction. It helps you also look at a bit about prognosis. Like the higher the score, the poorer the prognosis, obviously. You can also use it to monitor and quantify the improvement that the patient's making with your interventions in response to treatment. So it looks at obviously like all the different systems. It looks at coagulopathies, respiration, liver function. Looks at your cardiovascular system and your mean arterial pressures. And then looks at your GCS, and then renal criteria are creatinine and urine output. Urine output is a really good marker of how well or unwell someone is with sepsis. Next slide, sorry. And the QSOFA score is a quicker version of that if you've not got time to look at the table. So often people can go query sepsis, do the QSOFA, and then in the meantime do the proper SOFA one. So it's a shortened version, allows a rapid assessment. Again, if you've got a score of about more equal to or more than 2, you need to start investigating. So the QSOFA doesn't need like blood tests or anything like that. You're just doing normal like OBS, and it's often what we use unknowingly in ED or anywhere else to diagnose someone with sepsis. So you've got tachypnea, altered mental state, and low systolics. Okay. Next question. Okay, so and the last 5 now. So 62-year-old man brought to ED with confusion, fever, hypertension after collapse at home. He's had a history of diabetes and recent urinary catheterization. He's quite febrile. He's tachycardic, hypovolemic, tachypneic, and he's confused. So if you remember what we talked about just now, you suspect septic shock. So according to ATLS principles, what is the most appropriate immediate next step in his management? You're going to give him bloods and get some cultures and antibiotics. You're going to put a catheter in, give him some vasopressin to improve his perfusion, give him some fluids. We're going to get an urgent CT to figure out what's going on with his abdomen and his pelvis. So it's ATLS principles. So A to E. He's maintaining his airway, isn't he? So you don't have to do anything about that. B, he is breathing. His saturations are not too bad. C, there's a problem with C. So you could do something about that. Which answer fits C? Yeah, that's very good. So whenever the question is important, what it's asking you according to ATLS principles. And someone's in shock. So any type of shock, you go A to E assessment and A to E management. So we'll move on to the answer. So it's administer crystalloid fluid bolus. Next slide, please. Yeah. So there's not a lot to this one. It's what I was talking about earlier. It's you follow the ATE framework. This person is in circulatory shock, needs fluid resus before giving them vasopressors or anything like that, unless you've got pulmonary edema. So in septic shock, you want to give them fluid boluses within the first hour. You're right, you do give them antibiotics within the first hour as well, but the hypovolemic, you need to correct that first. Okay, so you only give them vasopressors if the fluids don't work. And antibiotics and cultures and equally source control, everything's important, but you need to do the ABCs first. Okay. Next slide, please. go on to the next slide now. Thank you. So question 17, 22-year-old man, he's got a circumferential full thickness burn to his leg following entrapment in a car fire, and he's got no fractures. He's 2 hours post-injury though, and he's got tingling sensation as his leg appears very dusky in colour. What's your next most appropriate step? So you could just vote and then we'll move on. Yeah. Okay, so we've got a 50-50 split there. We'll go to the next slide. So yeah, it's an escherotomy. Fasciotomy is of a compartment syndrome. You're right in thinking that maybe tingling is it that, and it could be both. Maybe the question could be a bit better, but because he's got a circumferential burn injury, it's more, well, basically a burn, and you want to do an escherotomy. So a bit about burns. You've got different types. You've got epidermal, superficial partial, deep partial, and a full thickness burn. The really quick way of remembering it is deeper it is, the more asensate it is, the more superficial it is, the more painful it is. You don't get blisters with deep ones. So if someone's got a burn history and they haven't got blisters and they don't feel pain when you touch it, that's more worrying than someone who's screaming the house down and they've got blisters. Okay. Colour is really important, texture is important. So if you've got dry and leathery, not good. You really need to refer them to plastics because they might need graft after debridement and things like that, which is done in the same procedure sometimes. Or they debride it and then they put a vacuum dressing on, vacuum pressure dressing on, and then graft it later. Okay. Next slide. Yeah. So a bit more about burns. We'll go because there's I think 1 or 2 more questions about burns later, so then you can apply these. So in terms of burn depth assessments, you're looking at sensation, blanching, bleeding if you prick it with a little needle, and just general visual inspection. You try and estimate it using either Lunter-Bauer, Wallace rule of 9s, or Palmer method. So 1 palm equals 1 is equal to 0.8 total body surface area. In children, you want to use a Lunter-Bauer chart, which comes pre-packaged in your ED paperwork. It's like a map of the body. And then moving on to initial resuscitation. So if it's more than 15% in adults, IV fluids, and then more than 10% in children, IV fluids. You use the Parkland formula. So you multiply the percentage body surface area with the weight, times it by formula Ringer's lactate. You give the first half in the first 8 hours, and you give the second half over the next 16 hours. So you're giving them all of that fluid within the first day. And it's since the burn, not since presentation, since the burn. So if they present 4 hours after the burn, you've got to give that first half within the next 4 hours, right? Does that make sense? Hopefully it does. Pop a message if it doesn't. And then you want to insert a urinary catheter and make sure you give them analgesia. Other principles are obviously stop the burn, so cooling as much as you can, 20 minutes minimum, if not more. You don't need to give them prophylactic antibiotics unless you think that it's contaminated with things. Topical antibiotics are not routinely required, and complex burns need surgical excision and grafting. Next slide, please. So what we're just going to go over sort of systemic effects, escalation, advanced care. So with response to major burns, you get fluid loss, you get hypovolemic, you get third spacing, so you get edema, hands, legs, listen to their chest, they might have pulmonary edema. You can get immunosuppression, you get basically a catabolic state, and so you've got increased risk of sepsis, especially with larger burns. You want to refer them to a burn centre, especially if they've got burn shock, or if they've got burns to the face, hands, genitals, or perineum, because those are more difficult to handle. If you've got deep, partial, or full thickness burns, they need to go to the centre, and chemical and electrical burns as well. I think to a degree some inhalation burns do go as well. And then obviously if you've got more than 10% of burn in adult or more than 5% in children, they go to a burn centre. As in this case, needed an escherotomy. Circumferential full thickness burns will need that. So in the limbs, you do it in essence to prevent the compartment syndrome. If you don't, then you'll need an escherotomy and a fasciotomy. Okay. And if it's to the torso, you do it to improve ventilation, because you'll get circumferential contraction, you just won't be able to breathe. Okay. So if you get a burn, if they've got inhalation burn or burns to the chest, one of the first things you want to do is intubate that patient, depending on their stats, obviously. But if they've got that level of burn, they might have, when the anaesthetist has a look down the throat, they'll see sort of like soot and charring around. So you want to intubate as fast as you can, because it will contract and your air will slowly start just going. So it involves surgical division of stiff burn scars, essentially. Okay, our next question. You've got a 68-year-old man involved in a low-impact road traffic collision, suffers a minor head injury, he's got a small scalp laceration, he's got AFib, he takes imbisoprolol and dabigatran for that. He's a bit drowsy, his GCS is 12, but he's got no other focal neurological deficit. What's the next most appropriate management? And sometimes in the question they won't tell you; they'll just tell you that they've got AFib that's well controlled. That's it. Okay, got one response. Wait for one more, and then we'll go through it. Okay, we'll go through it. So, well done, you got the answer right. Syringe CT scan means you memorised that nice guideline to heart, clearly. Well done. So a bit about head injury, but yeah, so essentially head injury with anticoagulation, immediate CT scan. Don't even need to think about it. You want to assess assess within the 15 minutes of arrival. You want to assess all three components of GCS and stabilise the airway, mobilise the spine, as we know with ATLS principles. You get your C-spine imaging with any head injury, including CT head, within the hour. You're assessing for any battle signs, CSF leak, focal neurology, or if they've got more than one episode of vomiting, or any post-traumatic seizures as well, or any suspected open or depressed skull fractures, are all indications for CT imaging within the hour. Equally, also with GCS less than 12 on arrival, or GCS less than 15 after 2 hours of observation in ED. You want to contact neurosurgery, especially if they've got persistent GCS less than 8. You will have intubated them by this point, hopefully, because less than 8 intubate. Or if they've got unexplained confusion for more than 4 hours. The other thing to really important is if you've got deteriorating GCS, so not quite hit 8, but you've got progressive just deterioration, or you've got incomplete recovery. Obviously, you will do if you've got penetrating head injury, etc. You want to keep them on neuroobs. Sometimes places keep them on 15-minute neuroobs, or sometimes it's 30 minutes. I think personally I would keep them on 15. That's what I've seen so far. And then anticoagulation patients consider a CT scan. It's not mandatory in all cases, but with someone who is, and they've got any of those indicators on this table, I would do it. I would do a CT head. Right, next slide, please. So question 19, 10-year-old boy is injured when a firework explodes, causing a full thickness burn to his left arm. Which of the following statements does not typically apply to this type of injury? So it's testing your knowledge of deep and superficial, which is like the too broad. Obviously, there's subtleties within each one, but okay. Just wait for one other reply, and then we'll go through it. Okay, next slide, please. Yeah, so you're correct. So full thickness burn damages the entire dermis and underlying skin. It will appear leathery, often white. They're quite painless. Well, not quite. They are painless initially, and then as the nerve endings start to regenerate on their own a little bit, they start becoming more painful later, especially after skin grafting, and they don't blanch under pressure. So well done. And the last question. You've got a 24-year-old man arrives at the ED with a crush injury to his forearm. He's got tenderness, redness, swelling of his arm. He's got an ulnar fracture. Sad times for that. But he's unable to move his fingers. So what is the next best step in his management? There's usually one that's really obvious that you're not going to do. And then you can work out the rest normally. Okay. So it's tender, red, swelling, ulnar fracture, not able to move his fingers, crush injury. Okay, it's a confusing one. I think this is slightly MRCS level, so we'll move on to the next slide and we'll go through why. Okay. So this is essentially, he's got compartment syndrome. So I think, how do I put it? In anything trauma, ATLS, there's always going to be like a distracting injury. So the distracting injury here is the ulnar fracture. He has got a fracture. It probably does need repairing. But the more important thing is that his limb is not neurovascularly intact right now, because he's got tingling and he can't move his fingers, and he's got massive swelling that's tender. So tender, painful, not good. Okay, so these patients need urgent fasciotomy as opposed to escherotomy, right? So, and it's quite common in crush injuries, although you would think with a crush injury you've like crushed it, right? But if they've not said in the question that he's got an open fracture, so it was a crush injury and he had a cut and the fracture, then there's somewhere for all the edema and the blood and whatever to like escape, but he didn't have that. So you're worried about a compartment syndrome, especially with those clinical findings. So it's defined as raised pressure within a closed anatomical space after a fracture, or you've got ischemic reperfusion injury leading to compromise of tissue blood flow, and necrosis. So you can use something called a manometer or a slit catheter, which I've got an example of on the bottom right hand side. So that's a Stryker, which is one of the brands. It's more common in supracondylar fractures and tibial shaft fractures in the lower limb, obviously. You get severe pain. Sometimes, you get severe pain worsened by movement, even passive movements. You get paresthesia. Pallor might be present, so you can start thinking also a little bit about ischemic limb, but not quite. Arterial pulses are still often palpable because arteries are always anatomically deeper than veins, so you can usually still feel them. And so the further away from the trauma they are, they're more likely to be intact. So abnormal is more than 20, got more than 40 pressures, then it confirms the diagnosis. Treatments, extensive fasciotomy, relieve the pressure, you just make a big incision all the way down. And lower limb decompression requires thorough, a really good technique, so you avoid missing any deep muscles. And then you can get myoglobinuria causing renal failure, so you make sure that these patients are also on fluids. And the principle is take off the dead muscle, it must be debrided. Sometimes you do need to amputate it, so probably not suitable for F1 when you start, but you might have to have that discussion with the patient before surgery if they are awake enough and alert enough from the trauma, because otherwise the muscle death can occur within 4 to 6 hours of any muscle group above it. Okay, I think that's my lot. We'll have another break and then we'll come back to finish up.
Yes, I think let's give, should we give till 5:15? 5 minutes-ish, and then hopefully we can do the last session and we'll get you guys out fairly on time. So yeah, thanks Dee.
Hey guys, just setting things up a little bit right now as we reach the quarter past mark for 12 p.m. for the final 10 questions of the lecture. Right, so let's just skip down to the last bit of the presentation. Right. Yep, so let's get cracking on with the rest of the presentation. So, in this next scenario, as you are trudging through your shift in A&E, you encounter a 22-year-old female that was rushed into the emergency department by paramedics after her family noted that her body was shaken and stiffening up. The paramedics that brought her in stated that she has had recurrent episodes of 1 minute tonic-clonic seizures from finding her on the street, and this was also occurring throughout the ambulance ride. Her mother provided a collateral history that she is known to the neurology team in the same trust for managing tonic-clonic epilepsy, where she is taking levetiracetam for prophylaxis. She otherwise has no other medical history or drug history. She's normally fit and well and has no known drug allergies as well. Due to the seriousness of the issue, the A&T team are suspecting that due to how many times she's been having these seizures, she could have a potential to develop status epilepticus. So, based on these choices, what would be the most likely definition of status epilepticus? Right, yeah, we got one response from this. I'm just seeing if anyone else wants to give it a crack. All right. I think just for the sake of time, we're just going to be moving on for the one answer. I can see why someone would choose two or more seizures just because it's been happening for quite a long time. But the reason I want to cover this question is to really put through the point of the basics that status epilepticus is by far the definition that an episode, so one episode of seizures that lasts for 5 minutes or longer without any recovery of consciousness. And this is a really important point to put forward because you see seizures quite regularly in the emergency department, but you have to try to distinguish which ones you want to escalate even further, just which ones you want to inform the anesthetic team, which one you want to feel worried that, yeah, we need to give a lot of the medications and stuff, and who has the potential to deteriorate. So, status epilepticus is, as we said earlier, a episode of seizure lasting 5 minutes or more without any recovery of consciousness. These can occur one over the other, but there's no recovery between each of the episodes. So in the stem of the question, she was able to recover, but she was approaching the point where that could be the risk, which is why the team were concerned. Risk factors for status epilepticus, or possibly causes of it, was poor compliance with anti-epileptics, alcohol withdrawal, electrolyte imbalances, low blood sugars for hypoglycemia, any form of trauma, especially head trauma. Infection can cause a substance abuse, such as cocaine, heroin use, and eclampsia as a late complication for pregnant mothers. As we mentioned earlier, it's a continuous tonic-clonic seizure, so they stiffen up, they shake, and stiffen up again. Their GCS is very low, and it could be rapidly deteriorating at a point. It fluctuates a lot, and it can be quite confused as well. And the thing is, without that recovery of consciousness and being going on for 5 minutes, we need to do something about it. So the pathway for this is that for the first line, it depends if you're in a pre-hospital setting or in a hospital setting. If this happens in a GP setting, for example, or somewhere in the community, or with the ambulance crew as well, they will probably administer some diazepam as a PR, so up the rectum as well, or bocomadazolam is shown to also cause as an option to treat this. However, because if someone is having these tonic-clonic seizures, their teeth and everything will also stiffen up and release and stiffen up. So there is a risk of when you put your finger inside someone's mouth that's seizing, they might bite your finger off. And there's been reports of this quite a few times before. So the PR diazepam is more preferred. Otherwise, if they're in a hospital setting, you just go straight to lorazepam, 4 milligrams. Each time you give this, you have to wait for a period of 5 minutes, adhering to the definition. If it recovers within that 5 minutes and they regain consciousness, then you stop. But if it doesn't happen, then you do this again and again with the next step. So you do the lorazepam twice before you think about phenytoin and infusion and phenobarbital infusion if the ED doesn't have it. This is 50 milligrams per kilogram. 50 micrograms per kilogram. And when you get up to the stage, you have to inform the ITU team to prepare just in case that they were to deteriorate even further from this. And again, you wait for 5 minutes. By this time, if they still have no response, or since the onset of the seizures for 45 minutes, there's nothing that's improved, then you need to do a rapid induction of general anesthesia with propofol to put them under intubation temporarily until you can treat the underlying cause of the seizure with your investigations. This diagram over here, as you can see after recording, is taken from the Oxford Handbook of Medicine, and you can also find it in your foundation program book as well. But if you have those books, you can have a look over there. If not, then you can always find this after this lecture is posted as a PDF or as a recording. So in the next bit, you suddenly have a 50-year-old lady presenting to your A&E department with a history of sudden onset weakness on the left arm and left leg. Her husband that has came along with her with the ambulance also noted a left-sided facial droop that developed over the last 13 minutes. Her memory remains intact and there is no sensation loss or paresthesia. There's no neglect or dysdiadoral kinesia was noted as well. That was meant to say there was no dysphagia throughout the conversation, so that was a typo over there. And she was able to follow commands otherwise when you talk to her and she was interacting in a conversation with a GCS of 15 out of 15. In a panic, you just want to think, is this a stroke or not? So based on these choices, which is the scoring system that you would use to quickly screen for potential stroke? All right, I think, again, for time, we're just going to rush through a little bit for this one. I can see most people have answered. The answer is C, the NIHSS score. The Rockwell scores for your first score for mortality for an upper GI bleed. Child Vasquez for AF assaulting anticoagulation. Gardner classifications for intracapsular fractures of the hip. And then Alberta scoring system is for assessing the CT head scans of a stroke to see if it's more likely to be a stroke or not. This screenshot over here is just a glimpse and a summary of what the NIHSS covers. And normally on call, because there's so many things to cover, you usually have a pen and paper in the ED that you can tick the boxes as you do the assessment. But essentially, it's quickly trying to see the level of consciousness, their alertness, the ability to follow the commands, quickly go through their visual fields and their gaze with their the gaze with their eyes as well. See if they have any motor or sensory deficit, and see if they're able to walk, have any language issues, have any swallowing issues as well, and ability to recognize people, place, and time, and objects as well to test their memory. So it's a very quick score, nothing very specific, but it does tell you to see if it's likely to be a ischemic stroke or not. So regardless of what the NIHSS is, you always do a CT head, and if the NIHSS is above 6, then you might think, it's more likely to be an ischemic stroke. I must do a CT intracranial angiogram to assess the vessels, but you must speak to a stroke registrar or stroke consultant first before you go for the next step. So with the same woman, in this case, using the Bamford classification, what type of stroke is most likely occurring at this point? And this slide has the correction of the type of where there is no dysphagia throughout the conversation. Just give one more minute for everyone to just have a think about this. All right, yeah. So we just got a response over here, and it is indeed a right lacuna stroke. As you know, strokes are always opposites due to the motor pathways that's going over there. Just to go into summary, the Bamford Oxford stroke classification categorizes stroke to see what the intensity of is. Just to quickly, before you do a CT or MRI, to go further based on the symptoms. The reason it is a lacuna stroke is because it only contains motor symptoms. As you can see in the table, the criteria involves is either pure sensory, so only sensory symptoms, pure motor symptoms, so only motor symptoms, and if they have any ataxic hemiparesis, so which means they have uncoordinated walking with certain weakness only on one side of their limb. More commonly, you see TACs and PACs, which are a bit more difficult to distinguish. Total anterior circular stroke attacks have all three of the following criteria. So they have a unilateral weakness, homonymous hemianopia, so there's one half of the vision on both eyes they're unable to see, and higher cerebellar dysfunction, meaning that these higher cortical functions they're not able to do. It could be that they are not interpreting objects properly, they're not recognizing people that well, their personality has suddenly changed, maybe there's some elements of hearing loss. It's basically quite advanced brain functions, to put it simply. A PAX, on the other hand, would only require 2 out of the 3 I mentioned earlier. POCs are a bit more tricky as they mainly occur on eye movement and a visual deficit as well. And they could be confused with other visual deficits from the visual pathway as well. as usual, just to summarize again from the neurology lecture back over there, you always do a CT head to rule out any hemorrhagic bleeds as well. Because if it turns out to be a hemorrhagic bleed and you give them anticoagulants and everything else, then you're going to make that bleed evolve even more and you're going to make the hematoma even worse. So if it's a hemorrhagic stroke, you want to go for a neurosurgical referral for hematoma evacuation. And while you prep them for theatre, you want to do some supportive management, prevent further deterioration, as well as do your blood tests and everything just to prepare them for operation, basically. Where it gets a bit more interesting and in a more of our control is an ischemic stroke, where we have to take a good history to see the onset of symptoms from the window. If it's within the window, they can take alteplase and tenecteplase, which are plasminogen factor inhibitors, and this is your thrombolysis pathway. If not, then you will want to load them with some antiplatelets from aspirin on clopidogrel as well. Aspirin you continue for 2 weeks. Clopidogrel you continue them as lifelong for prevention in the long term. If in your from your NIHSS score, they score above 6, you do a CT intracranial angiogram, you find that there is some large vessel occlusions and it's within the proximal orbital parts of that particular cerebral artery. They are easily able to reach with the machine used for mechanical thrombectomy, and you are more likely to have high success rate if this is done from 24 hours from the onset of symptoms as well. And the long-term prevention will, as I said, clopidogrel, and you need to give them hydrostatin, such as atorvastatin, 80 milligrams once a day as well as some potential risk factors such as AF, which you need to give your DOACs, for example. All right, so back to some more patients that are feeling unwell. You decide to move on to a 64-year-old gentleman who is found drowsy and laid down on the side of the street by a bystander who phoned the paramedics. In the A&E department, he wasn't able to identify where he was, who the hospital staff were, and thinks he is in jail. The HCAs and the A&E nurses describe him as always on edge. Examining him, you notice that as he was pacing around the side room where he was being kept, he was not able to keep his balance. You noted, just looking at him, that his left eye is abducted towards the left side. He scores an 8 on the 480 score, and he's very agitated and aggressive, so you're not able to do any more further assessments, such as assessment in the chest, assessment in his breathing, or do a neurological exam. Based on the likely presentation from this, and what you think the most likely diagnosis is, what would be the most likely management step that you should undertake? Some interesting choices over here, actually. I'm wondering, for the person who picked A, what do you think the diagnosis is? If you're brave enough to type it in the chat. So it is actually Wernicke's encephalopathy in this case, because you have your ataxia, which is his unbalanced walking around, his confusion and agitation, and the abducted left eye represents ophthalmoplegia. However, the treatment that you've chosen for A is not the treatment for Wernicke's encephalopathy. It's for hepatic encephalopathy, which is caused from advanced liver cirrhosis or post-TIPS procedure. In this case, the answer is actually B, which is IV thiamine and then IV dextrose. So correct diagnosis, but wrong treatment. But we'll cover that in a bit. So as I said earlier, lactulose is for hepatic encephalopathy, which you should also read about when you have time. IV dexamethasone, metronidazole, and cyclothiols to cover for encephalitis, which is less likely in this case because encephalitis usually only presents as acute confusion, but you rule out every other possibility diagnosis such as infection and delirium from like UTI or pneumonia or any other underlying cause that could cause a delirium. IV immunoglobulins, again, could be for other conditions as well, but not really indicated for this. And CT head outer place is not really a ischemic stroke, so less likely to be that bit. But essentially, in summary, Wernicke's encephalopathy is a neuropsychiatric disorder caused by thiamine deficiency, and this is usually caused by a chronic consumption of alcohol. That is why you see it common in alcoholics. However, you can see in other types of people as well that are more prone to become deficient in thiamine. Mothers in the early stages of pregnancy who vomit a lot can lose thiamine that way, and it can cause hyperemesis gravidarum, which leading to Wernicke's encephalopathy. Stomach cancer and vitamin B1 deficiency due to the lack of digestion and breakdown of thiamine. Just the lack of intake of thiamine in foods as well leads to beriberi syndrome, which is just B1 deficiency, aka thiamine. And people undergoing bariatric surgery as well because thiamine is mainly broken down in the stomach. Without a stomach or less of a surface area of the stomach, you absorb less thiamine. You want to be thorough in your investigations, and you want to make sure there's nothing underlying as well. But based on this history, it's most likely Wernicke's. Therefore, you want to give them thiamine as soon as possible. And because they're chronically dependent on alcohol, such as in this case, you want to give them some glucose afterwards, as you want to assume that they had no nutritional intake from anything else. But why do we give thiamine first before glucose? Well, glucose metabolism is dependent on thiamine. So if you give glucose first and then thiamine, your body is just going to use up all the thiamine you pumped into it, and then you're back to square one. You're not really correcting the thiamine levels. So you want to give them thiamine first, and then you give them the glucose afterwards. But you want to you do want to initiate supportive treatment throughout the entire thing for them to recover. And you might consider doing a capacity assessment and probably a dose as well, because they probably wouldn't be orientated during this time of treatment and have capacity to even consider for treatment. As a small note as well, you may hear Korsakoff's being added on when people talk about Wernicke's, and this is actually a late stage of Wernicke's encephalopathy. So when they start to get amnesia, anterograde or retrograde, which means they are not able to remember what has happened in the past, and they almost make up things that are happening in the present as well or in the future. That's anterograde and retrograde amnesia. And they also confabulate, which means they make up stories, or the stories change every time you ask them the very same question. This is a very late stage of Wernicke's encephalopathy called Korsakoff's encephalopathy as well. So after going through all of that, you decide to take a little bit of a breather and then come back to A&E, and then you have more unwell people. A 72-year-old woman presents to her GP initially after a recent episode of fainting while getting out of bed in the morning. She reports she feels lightheaded, sweaty, and nauseated just before losing consciousness for a few seconds. I just meant to say A&E, not GP, but she recovered spontaneously and felt tired, but otherwise as well. Past medical history includes hypertension, type 2 diabetes, and osteoarthritis. Medications include amlodipine, metformin, and paracetamol. On examination, her supine blood pressure is 138/82, and it drops to 102/68 after standing for 3 minutes. And there has been some dizziness reported. So, based on what's been going on and your most likely diagnosis, what explains the mechanism of the condition that she's experiencing right now? Right. Yeah, I'm just gonna move on. You know what? I think everyone has got the correct answer, which is very good, actually. Very important to distinguish the mechanism, and I think something that we kind of neglect when we are studying conditions. So this is a vasovagal syncope or vasovagal episode, and is usually caused by reflex bradycardia secondary to standing-induced venous pooling in this case. So what are vasovagal syncopes? Vasovagal attacks are triggered from a sudden reflex bradycardia due to unopposed parasympathetic inhibition. This results in a brief loss of consciousness, lightheadedness, and visual disturbance, nausea, sweating. But the key thing in the history to distinguish from other types of syncope or passing out is that they are very prompt to recover after an episode, and they're able to remember what happened before the syncope or before the fall, during the fall to an extent, and afterwards as well. There are a very wide variety of causes, including prolonged standing, fear such as from seeing the sight of needles, pain, nausea and vomiting and dehydration, excessive straining, excessive coughing, and peeing as well, micturition. It can also cause from insertion of an IUD or IUS, termed cervical shock due to stimulation of the cervix as you're inserting the device. And certain medications such as digoxin, beta blockers, amiodarone, verapamil can also cause it as well. The key is to do a line-standing blood pressure and maybe even a tilt table test if that's not safe enough for the patient. And the definition of vasovagal syncope or orthostatic hypotension is that there must be a 20 millimoles of mercury difference for systolic blood pressure and 10 for diastolic blood pressure as well. Usually, if you manage the underlying cause, it should resolve by itself. But if, regardless, there is no underlying cause and they're still having recurrent episodes from this, commonly presents recurrent falls, you term it as orthostatic hypotension. That's when you need to give medications to assist in poking up the blood pressure other than your tablets or stopping antihypertensives or reducing the doses. You can give mineral corticoids such as fludrocortisone, which increase sodium absorption, increase fluid absorption, increasing your blood pressure in the long term. But if that doesn't work, you need to consider midodrine as well. In this case, you see a different patient, this time a 75-year-old man, who was initially admitted by his GP to the urgent treatment center just next door to the A&E before losing consciousness suddenly while in the waiting room there. And then he's just been brought back into A&E doors, adding to the patient list that you've already been having. He has been feeling increasingly fatigued and lightheaded over the past 2 days, and earlier he briefly lost consciousness while walking to the kitchen. He doesn't actually remember the events as concern from walking towards going onto the floor. And his concerned wife also reports that she heard him fall before rushing to the kitchen and found him on the side. Medications include a medical history includes hypertension, AF, and chronic kidney disease. And he takes bisoprolol, ramipril, and apixaban. He says he's been getting forgetful over time, so he has decided to get a dosette box to help him organize tablets, but he admits he may have forgotten on which tablet is which and what they look like when putting them in the boxes. He's GCS 15 out of 15. His heart rate is 38. Blood pressure is 90/60 on lying, but he was unsafe to do with standing or sitting up due to feeling blacking out. And his blood glucose is 5.6. Based on the above, what is your best first line management step? I'm just going to give it another minute for a chance to give it a go. Okay, so yeah, we have 1A and 1D over here. Okay, I see here. So based on the answers over here, the answer is actually D. And well done for whoever answered that, not falling into the trap and actually reading the units and the doses for this. This is an example of cardiac syncope caused by hemodynamic instability from bradycardia as well. So they're being quite unwell, and we need to act very promptly. The reason why, titrating bisoprolol 2.5 milligrams is something we can think about for the future, but that's not the priority right now. He's been actively hemodynamically unstable, so we need to pounce in on the action over here. This question basically tests your knowledge on the resource guidelines for adult bradycardia as well. So if you find any signs of shock, syncope, that could point to the direction for life-threatening features of bradycardia, then you need to act by giving some atropine first to try to increase the heart rate. And this is 500 micrograms IV. And you can repeat this up to a maximum of 300 milligrams. If that doesn't work, you will need to discuss with cardiology further, who may advise on other alternatives of atropine, such as isoprenaline, adrenaline, dopamine, and glucagon as well. But don't go ahead and do that unless cardiology says what is what. If that all doesn't work, then you only go to transcutaneous pacing, which is pacing through the skin, and transvenous pacing, which is putting a lead through the vena cava and pacing the atrial nodes through the vein, basically. But you only go through this pathway when there is signs of life-threatening bradycardia, such as in this case where he has syncope. That being said, cardiac syncope, there are many different causes of it. So there's AF, heart failure, MI, heart blocks, arrhythmias, pulmonary embolism, valvular diseases such as aortic stenosis, and cardiomyopathies such as hypertrophic cardiomyopathy as well. I forgot to add it on the slide, but a key feature of cardiac syncope, as mentioned in that history, is that they do not remember what has happened, or they can't recall the events prior to the fall or the blackout, as they call it. That's your key feature, the distinction between a vasovagal and a cardiac cause. And to really understand what this cardiac cause is, we have to do an ECG, monitor the heart rate and the observations continuously. You might book them for a Holter monitor to see if there are any ectopics or any episodes of asystole or bradycardia picked up over a 24-40 hour period. You might do an echo to try to see if there's any valvular disease, an exercise stress test to see if exertion causes them to black out more, and review their medications, such as in that choice, we might decrease the bisoprolol in case as well. So I guess overall, in that case, what could be causing that? Well, we know that his dorsal boxes get mixed up. He could have overdosed on his bisoprolol as well, which is why we probably need to consolidate his medications and labeling his dorsal boxes as well. We move on from that and we go into the world of pediatrics for this case, where you see a 16-year-old boy being brought into the Pete's ED with a 2-day history of feeling generally unwell after his school called the ambulance. He complains of mild, vague abdominal discomfort, nausea, and vomiting. He also says he's been quite thirsty and has had a lot of urine over the past week. Examination, he's lethargic with dry mucous membranes. His respiratory rate is 26 per minute with a deep labored breathing. His heart rate is 110 and his blood pressure is 100/60. Capillary blood glucose is 28. So based on all of this, what is the most likely diagnosis? Oh yeah, everyone's very quick for this one. We all like the what's the most likely diagnosis questions. Yep, everyone's answered it. Yep, everyone's got a correct answer. I can probably move on from this. It's diabetic ketoacidosis. So just to have a quick run through, it's a emergency classically associated with type 1 diabetes. Is due to a lack of insulin produced from your autoimmune reactions on the pancreas, preventing their release due to attacking the beta cells. This forces the body into a starvation state, where the cells have to undergo ketoneogenesis to make ketones for energy. Ketones are quite acidic, therefore will cause metabolic acidosis in the blood as well. And with a low pH, your body can't function as normal functions well. Criteria for DKA, since the symptoms are not specific, is that the glucose must be above 11 millimoles. There must be evidence of ketones above 3 millimoles in the blood, or ketones or 2+ on your urine dip, and on a blood gas, arterial or venous. There must be a pH of at least 7.3 and a low bicarb of 15.0 to show quite a severe metabolic acidosis. Other signs that you may see in later DKA, I forgot to mention, is that you can get fruity breaths, which are due to the ketones being produced, and cause more respiration or hyperventilation. Management is fluids. A fixed rate of insulin to try to drive the glucose down at a rate of 0.1 units per kilogram per hour, and to continue their basal long-acting insulin. And whilst doing all of that, you need to have regular monitoring of the glucose to prevent them from going to any hypos, and to see if their pH is starting to go up. If, regardless of that, if the pH is still going down and it's below 7.1, you need to escalate to ITU. And this is just a brief slide to note hyperosmolar hypoglycemic state, or HHS, which is the other side of the spectrum. It mainly affects type 2 diabetics and more elderly people compared to DKA, which is for younger people with type 1. Essentially, they do not have any ketonemia or any acidosis, but their glucose is astronomically high at least 30 millimoles or above, and the serum osmolarity, when you calculate it, is above 320. You calculate it by taking the level of sodium, level of potassium, and timesing each of those by 2, and adding the numbers for glucose and urea in the blood as well. Management is quite similar, except you give your insulin infusion at a rate of 0.05 units per kilogram per hour as well. With the same boy, he is admitted to the pediatric acute medical unit next to A&E just to try to stabilize everything. The team decides to read the past medical notes, and he's actually been known to have insulin for type 1 diabetes managed under the endocrine team. This was further reviewed by the on-call registrar. However, when he or she went to talk to the boy admits that he has been intentionally withdrawing his insulin doses over the past 2 days. The boy admits that he has Googled what will happen if he doesn't take insulin last week, and he has been planning to do all of the above of holding insulin since last week as well. He knows that life isn't worth living anymore, and he is a worthless shadow. He confirms that he hasn't done anything else as his household is strict, and he cannot find opportunity to do anything else at school. Despite being aware of the risk and asking if he wants help, he confirms that he would rather die than have anyone waste their time on me. The registrar is thinking of implementing the Mental Health Act of 1983. Which of these sections would be most appropriate in this situation? Okay, yeah. So I can see where everyone is going. The answer actually would be a section 2 in this case, and we will go through each of the several sections and why. So a section 2 allows for detention of assessment for up to 28 days when the patient is at risk to self-harm or others and refuses to or lacks the capacity to consent to admission. Basically, in psychiatry, this is termed as a lack of insight into their condition or their health. This must be done by two health professionals who are Section 12(2) approved. So these either can be doctors, which are Foundation Year 2 or above. So when you guys start at F1, you can't do this yet until you're F2. And one acute mental health practitioner as well. Section 3s are for longer term treatments up to 6 months, but they can only be done after Section 2. Section 5(4)s are for registered medical nurses that can detain an individual up to 6 hours before a Section 2. Section 5(2)s are when doctors can detain an individual up to 72 hours prior to Section 2 assessment, but I got to add that that's more likely the case if there is a risk of absconsion or the patient leaving the ward that they were put in. In this case, there's no evidence to suggest that at all, so that's why we're not putting that first. And a Section 136 is when an individual in a public place is a danger to themselves and others, and it's mainly to grant police temporary holding powers to hold them for up to 72 hours for a doctor and an AMHP to do a mental health act assessment. Do note that an emergency department does count as a public space, and you can't do any of these sections until you're admitted to a ward, which was done over in this case where they were admitted to AMU. So we go down the psychiatry theme where you see another patient, a 24-year-old man with a history of schizophrenia, who was started on aripiprazole 1 week ago. He now presents with a 2-day history of high fever, muscle stiffness, confusion, and sweating. On examination, you note that his temperature is 39.2 Celsius, his heart rate is 115, his blood pressure is 160/95, and he has lead pipe rigidity. His bloods show that he has elevated creatine kinase and leukocytosis. What is the most likely diagnosis that we're dealing with in this case? Whew. 50-50 split again. All right, okay. Yeah, so I can see why someone would put serotonin syndrome for this. It does present very similarly. However, the muscle stiffness, the rigidity, the elevated CK points left like so, and is usually used for other medications as well. So this is most likely B, neuroleptic malignant syndrome. Neuroleptic malignant syndrome is a rare life-threatening reaction to any antipsychotic. Most typical antipsychotics. However, atypical antipsychotics are just as risky, even though the rates are less. They usually present as having a fever, having rigid muscles, sweating, and autonomic symptoms as well. And because of the persistent muscle rigidity, they can get a rhabdomyolysis from it as well, and that can cause them to get into renal failure. With a fever, they can get into dehydration and seizures and hypothermia as well. As I mentioned, the risk of the antipsychotics, young men are also at risk who are taking these medications, and high doses of antipsychotics also make you more predisposed to have this condition. Your treatment is to stop all antipsychotics, give them fluids, reduce their temperature and cool them down, oxygen if necessary, monitor their renal function for the whole time. So it's mainly supportive management with all of this. And psychiatry reviews for them to see any alternative antipsychotics or treatments in the future after this. Still under the theme of psychiatry, we see another man who's 45 years old, who's known to have bipolar on lithium therapy. He presents to the emergency department with nausea, vomiting, diarrhea, and increasing confusion over the past 24 hours. On examination, he is tremulous with an ataxic gait and shows coarse hand tremors. His serum lithium level is 2.1, which is over the range based on what the therapeutic range shows, and his ECG shows a prolonged QT interval. What is the most appropriate next step in management? Right, just have another 30 seconds, give everyone some time to answer. Okay. Right, so I can see why some people put introduced bicarb and everything. Okay, yeah, so the answer for this question is B, to actually discontinue the lithium and again supportive care with hydration as well. Uh, Lithium is a mood stabilizer for mania and bipolar disorder. And when you start lithium, you need to measure the levels 12 hours after the first dose and 4 to 7 days afterwards to check they're stabilized. Throughout this time, apart from their lithium levels, you need to monitor their UNEs, their thyroid functions, their BMI, their HbA1c, and their bone profile. And that's because lithium, despite being a good mood stabilizer, is known to have a lot of adverse effects, namely nausea and vomiting, fine tremors, nephrotoxicity, hypothyroidism, weight gain, and hypertension and leukocytosis, and hypocalcemia as well. Early signs of toxicity will include a tremor, agitation, first polyuria, and nausea and vomiting. Late signs are spasms, coma, arrhythmias, and AKI. So thankfully, this gentleman is in the early signs of toxicity. We need to stop the lithium and give them lots of fluids and monitor their blood with some supportive monitoring. Unfortunately, carbon and sodium bicarbonate actually do not work against any lithium toxicity at all. So, which is why the sodium bicarbonate is the incorrect answer in this case. Once you do the supportive monitoring and you get them all better, you need to liaise psychiatry, who probably will need to think about another mood stabilizer. Something like quetiapine may work, but it's based on what they think it is. That's a bit of a specialist psychiatry level that I'm a bit under underqualified to comment on that bit. But with good news for that reaches us to the end of the lecture. These are just some reminder for other psychiatry emergencies to note and to read about as well. And yeah, thank you so much for attending today's lecture and spending your weekend with us as well. And hopefully we can see you in on our following session. Yeah, cheers, Paul. It's nice to see you. You've been really well and attending all of our sessions. You're a well-known face to all of us.
Yeah, thanks for calling, Paul. It was a pleasure.
I think I'm over here to answer any questions, and so is Dipshika as well. So just be hanging around for the next 5 minutes, just in case you guys want to ask anything about what we covered.
I think we'll also be putting the presentation up after a while, uploading it. So yeah, that feel free to obviously use the resources because they're very good case examples to work through for exams. I hope you find it useful. I understand exams must be underway or either very close, coming up for anyone who's attended. So good luck to yourselves. It'll be fine. I think a lot of our content's usually targeted a bit harder. So if you come to some of our sessions, hopefully it's prepped you, but also kept it quite realistic as well. It's not too hard, not too taxing. But yeah, good luck to anyone who's having exams. And look forward to seeing you as future colleagues next year. And please keep coming to our sessions next week onwards. Shall we end it there? Yeah.
Yeah, I think everyone's kind of left right now.
Was it just us? That's fine. I'll that's yeah, thank you. Got it.